Uh, Good evening, everyone. So today we'll be just briefly reviewing what we know about airway management. So I would first like to thank Dr. Justin Gopal Das and the IDCCM Bangalore chapter for giving me this opportunity. So we'll keep this session as much interactive as possible. Yeah, so the one of the participants, each one of you take turns, unmute yourself and just start answering. Yeah. So we'll begin with just a moment. 1 second. Yeah. So yeah. So who will take the first turn? So please, one of you guys unmute and start answering this. People.
Oropharyngeal airway, sir.
Right. Yes. So the first question is, yeah, identify the parts of this briefly. Yeah. So,
there's a white block.
yes.
The shaft.
Okay. This is the bevel, right?
The lumen and the opening.
Yes. So indications and contraindications of this.
Indications is to enable us to clear secretions first, then to ventilate a patient.
Yes, yes.
A person who has a tongue fall.
Yes, exactly. Yeah.
A difficult airway.
Okay. That should be okay. Yeah. Contraindications.
Anyone with a facial injury, mandibular injury.
Yes. Okay. And obviously in the conscious and semi-conscious patients, you would like to avoid this, right? Because it will stimulate a gag reflex and lead on to aspiration. All right. So how would you estimate the correct size of this?
So we measure the size from the tragus, from the external ala of the nose to the.
Oh, that will be for the nasopharyngeal airway.
Right.
And this is the oropharyngeal.
Angle of mouth to the tragus. Angle. Yeah.
Angle of the mouth.
The mouth to the tragus.
Angle of the
tragus.
mandible.
Yeah.
All right. So there is another method to do this. Actually, from the incisors to the angle of the mandible. Yeah. So in 2016, they did a study on this and they found comparing both the methods, right?
Okay.
The incisors to the angle of the mandible and to the from the angle of the mouth to the angle of the mandible. So they were looking at the effectiveness of ventilation, and they found out that when in the group which measured from the incisors to the angle of the mouth, they had a better ventilation, right? So the angle of the mouth to the angle of the mandible, in that partial obstruction and complete obstruction of the airway was found. So leading on to inadequate ventilation. So I think, both the methods are good. Yeah. So, but this method is slightly better when it comes to ventilation, right? But the drawbacks of this method, that is the incisors to the angle of the mandible, in that study, they found out that up to 22% of the patients had the lumen, the bevel, going beyond the epiglottis. So the epiglottis injury and other things also has to be kept in mind. But when it comes to adequacy of ventilation, I think we can choose from the incisors to the angle of the mouth, right? Angle of the mandible rather, sorry. Okay. So insertion techniques, yeah, this I think, yeah. So how would you insert? Two techniques are there, definitely. Yeah. Yes, Sneha? I think.
So we insert with the opening the jaw with the concave curve towards the palate.
Exactly. Yeah. And once it's halfway through, you turn it and push it back. Push it, right?
Yes.
Yeah.
Yes.
The other method is maybe just give a chin lift and jaw thrust, and with the tongue depressor, you can put it along the concavity only, you can insert, right?
Right, sir.
Yeah. So since you already told about oropharyngeal, would you like to continue regarding nasopharyngeal? Because more or less it's the same.
Yes, sir.
Yeah.
So this is
the same.
Rubber nasopharyngeal airway.
Yes.
So
So
it has a flange and the...
Yep, and the bevel. Yeah. So this is usually silicone, latex, or rubber. The oropharyngeal is usually plastic. So it's hard. That is hard. This is soft, right? Yeah. So the size you were mentioning.
Yes, sir. The size is from, we measure it from the ala nasae, the lateral ala of the nose, to the tragus.
Tragus, right. So the insertion technique, yeah, I think. Now, the only thing here is when you're inserting it, make sure that when there is resistance, do not push beyond the resistance, maybe change the nostril. Yeah. Right. So that is one. Beyond resistance, if you push against the resistance, maybe you will be causing turbinate injury. Yeah. And this curve is approximately made according to the nasopharynx, right? Yeah. So indication and contraindication almost all the same, but indication in semi-conscious or conscious patients, you can still use this to maintain a patent airway, right?
Yes.
Okay. Yeah. Thanks, Dr.
Nasal fractures we cannot.
Nasal fractures you cannot. Yeah. Yeah. Thanks. Thank you, Sneha. Yeah. Okay. Who's going to take this?
So I'll just take this.
Yes. Sriram, Dr. Sriram, is it?
Yes, sir.
Yes.
Okay, this is an endotracheal tube, sir.
Yes, exactly.
We can use for the nasal also. The same endotracheal tube we can use for the nasal also. Oral as well as nasal, both.
Nasal, all right. Yeah. So
it's the parts.
Parts, yes, parts. Yes.
It's having a connector, sir.
Universal connector.
Connector
Okay.
that is 15 millimeters diameter.
Fantastic. Okay.
And it contains and a bevel at the end, sir. It's curved bevel, and it contains a Murphy's eye. Murphy's eye, sir.
Importance of Murphy's eye.
If this gets blocked, the main lumen gets blocked, it can ventilate through the other lumen.
Exactly.
Other Murphy's eye,
yes, exactly. Yeah. And this.
And there is a inflating balloon, sir.
Pilot balloon, cuff inflating pilot balloon. Yeah.
Pilot balloon, yeah. And this is a cuff. Yes,
okay, right. Cuff. And there is one radio opaque line throughout the ET tube, right?
Yes.
Yeah. Yes. Okay. So how would you define this cuff? This endotracheal tube cuff.
Sir, it's a high volume, low pressure cuff, sir.
Yes. Okay. Yeah. So what is the
benefit? High volume, low pressure cuff in order to prevent the cuff-related pressure necrosis.
Yes.
And if it is a high pressure, it causes a pressure necrosis of the tracheal mucosa. That's why we have changed it to high volume, low pressure.
Exactly. So which tubes have this low volume, high pressure cuffs?
Red rubber devices. Red rubber pediatric tube.
Red rubber tubes or even the flexometallic tubes, right?
Yes, sir.
Yeah. So, Sriram, what is the tracheal perfusion pressure?
Sir, it should be at
tracheal perfusion pressure. No, not the cuff pressure.
Sir.
Tracheal perfusion pressure. Yeah.
So I'm not sure about it.
35 to 40 mm.
Yeah, somewhere around 22 to 32 mmHg. If you can convert it to centimeters, it will come to 43.2 up to 43.2 centimeters, right? Yeah. So, and what do you think the cuff pressure should be?
So it should be between 25 to 30 mm.
It should be lesser than the perfusion pressure.
Exactly. Yeah. If it is higher than that,
pressure necrosis can occur.
Exactly. Yeah. So how would you confirm the placement of endotracheal tube?
So that black line has to be beyond the cord.
Yes. So one thing is you'll visualize, you'll see that the tube is passing through the vocal cords. That is number one. Yeah. Second thing.
Visual.
Then we
immediately you'll do one thing, right?
Auscultate the patient, sir, on the 5 areas of
auscultation. Right. Exactly. Yeah. Then
ETCO2 we can.
ETCO2. Okay.
Chest X-ray.
Then
and
fogging, sir.
Fogging, chest X-ray, yeah, and ventilator waveforms, chest rise, yeah. And recently you can even, we can even use the ultrasound to see the slide on both the pleura, and while passing, maybe you can see that it's not going into the esophagus, right?
Yes.
Yeah. Good, Sriram. Right. So would Dr. Ambika like to take this up?
So this is Pooja.
Pooja, okay. Right.
Indications are in difficult airway where the glottis is not visible. In order to guide the ETT into the trachea.
Yeah, maybe, that time you'll be, feeling the tracheal ring,
might be more anterior.
Ring. Yeah. That's fine. All right. Yeah. So what is the difference between this and the stillet?
Bougie is made up of Portex, and stillet material is steel material. Bougie is a little bit flexible, pliable than the stylet. And stylet is before intubation, we put it in the ETT and then do the intubation.
Yeah, but usually you are using a flexometallic tube and all. Yeah, right. Fantastic.
Yes.
Okay. Yeah.
Yes.
Right.
And bougie, we insert it first and then.
All right. So can you tell us about stiletto study?
Sir, I have not read about stiletto study.
So this study, can I tell, sir?
Yeah, please go ahead, Dr. Arpita. Yes.
So this study was done in critically ill patients. It showed that using the bougie or a stillet improved the success rate was high in the first attempt.
Yes, the first pass successful. Intubation was high with stiletto. Yeah, stiletto or the bougie. And it showed that the tracheal injuries it's very less, right? Anybody about intube study? Now we are talking about intubation. What did this study look into? Just a brief. Arpita? Okay. So Intube actually looked into the peri-intubation effects, and they found out that the major peri-intubation effects, the complication were related to cardiovascular complications, hypotension, and especially associated with use of propofol. Even in this study, they used a bougie or a stillet for successful first pass intubation, and the success rates were very high. Okay. Yeah. Yeah. Arpita, can you take this?
So this is a LMA, that is laryngeal mask airway.
Okay.
This is the first generation LMA.
Yes. Yeah.
So this also has a patient end.
All right.
This also has, it is connectable to the universal connector.
Yep. Yeah.
And this also has a cuff, inflatable cuff.
Yes.
So we usually deflate it and then insert it.
All right. And any significance of this particular shape?
That usually is takes the shape of the above the epiglottis. It sits above the epiglottis.
Yes, exactly. Yeah. So the insertion technique.
There are two techniques, sir.
Yeah.
Either you can hold it like a pen and insert it.
Yeah, exactly. Yeah.
And the other one is rotate and twist it.
I think the pen one is the easiest one, and you can actually feel that it's just going there and sitting. Yeah. Okay. So advantages and disadvantages.
Advantages, mainly it is a very important tool in the difficult airway.
Yes, exactly. Yeah.
Cart.
Yeah.
And it doesn't it can be easily inserted. Anybody can easily insert it.
Exactly. Yeah.
The disadvantages is it doesn't provide complete protection for the airway, like against aspiration.
Yes, yeah.
Just you can use it as a temporary measure.
Yeah.
In the
cannot
ICU.
intubate through.
So one more advantage actually with LMA is like the sedation is not required deep. I mean, relaxant is also not deep. It's not required.
Yeah, I mean, yeah, basically, but yes, exactly. But I mean, in the ICU per se, when you're using a LMA, most of the times you'll be using it for a difficult airway sort of a condition, right? Okay, good, Dr. Sriram. Yeah. So this one. So I think, Arpita, you can finish with this.
This is a iGel, sir.
Yes, exactly. So the only difference here is, what is, I mean, you don't have...
cuff. You don't have a cuff.
Yeah, and this itself...
And it usually, it's easier to insert than the first generation LMA. It just takes the shape of the... It's above the epiglottis.
Yeah, and it gets, it takes the shape.
It's made up of thermoelastic materials.
Yeah, thermoelastic material so that it can accommodate to the size and the shape of the pharynx. Okay, so what is one?
As inbuilt bite block.
Bite block, yeah. Okay, then something here.
Special port for the suction.
Yes, exactly. Right. So I'll just briefly tell you about the difficult airway sort of an algorithm for ICU patients. So this All India Institute of Difficult Airway, All India Difficult Airway Association, sorry. Yeah. So these guys were the first to come up with a difficult airway sort of guidelines for ICU patients, right? So the pre-oxygenation, I think it's all evident. So how do you guys pre-oxygenate in your setup?
So we generally use OptiFlow, sir, and keep the saturation to 100%. I put to 100% prior to this one. Depends upon the gadget, whatever the patient is on. If the patient is on an IV, we'll continue to...
Yes, exactly. Yeah, that's what I wanted to just make sure. If the patient is on NIV, you can, as per the settings here, you can continue to do that. Yeah, or even the HFNC, you can still do it. HFNC will have some apneic oxygenation benefits also. Right? Or if you're using the bag and hand with the bag, that also you can do. So the once if it is successful, it's okay. If it is not successful, then in the Indian difficult airway, they are saying you can have a maximum of 2 attempts, and maybe you can use a bougie and stillet if required, right? And if you fail there, you have 2 more attempts with supraglottic airway device. And if you are not able to succeed, then you have to declare can't intubate, can't ventilate, and can go for the cricothyroidotomy, right? So again, then came this Royal College of Anesthesiologists who also came up with their guidelines. The only thing is they have given 3 attempts, and they are saying that if you have a video, even including our thing, if you have a video laryngoscope, please use it. So I think many of us are using the video laryngoscopes, right? Yeah. So, and they are giving 3 attempts for maximum is 3 attempts before you go for front of the neck axis. All right. Yeah. So who's going to take this up? Yeah, somebody unmute and start talking about this particular waveform.
Sir, it's a capnograph waveform.
Oh, okay, Manudeep, yes, yeah.
Yes.
Yeah.
It's a capnograph waveform where from the phase 2, the expiration starts.
Okay, so phase 1 is what then?
Inspiration is still going on.
Yeah. Okay. Phase 2?
And phase 2 is start of expiration, and
right. Phase 2 has both
carbon dioxide from the
space and the alveolar.
Yeah. Yes, sir. And
phase 3?
Phase 3, yes, sir. Alveolar ventilation, still carbon dioxide from the alveolar, and the end of the phase 3, you will have end-tidal carbon dioxide.
Exactly. Yes.
Measurement. And again, once the patient starts inspiring, the carbon dioxide starts coming.
Right. Okay. So yes, so different types.
Yes, we have time capnograph and volume capnograph, sir.
Okay. Clinical uses of this?
Yes, major uses, it is used in OT as well as in ICU. In ICU for the confirmation of ET tube placement,
right.
And in neurosurgery, trauma head injury patients.
Yes, you can titrate your.
Yes.
Yeah, fine. Right. Then
adequacy of the ventilation during CPR.
Yeah, no, the next thing is that the question is coming up.
Yes.
Yeah. So how do you use it in ACLS, Dr. Manudeep?
Yes, sir. In ACLS, the effective CPR, to know the ETCO2, at least it should be more than 20.
Okay. Then one more thing, that is the effectiveness of CPR. Okay. You always try to maintain it at 20 or more than 20, and less than 10 associated with poor outcomes. Right. Yeah.
And also, even in the ACLS, like after securing airway.
No. Before that.
ROSC, sir.
Yes, exactly. Yes. Yeah. So there will be a sudden rise to more than 40. Okay.
No. Okay, sir.
Right. And there are some data regarding fluid resuscitation, and and with fluid resuscitation, you can see an increase in the ETCO2, provided there's an increase in the cardiac output. Okay. So Manudeep, just continue again. Yeah. So what is this? The first one, which I'm pointing here. I think you can see the pointer, right?
Rebreathing.
No.
Yes.
No, we'll imagine
this
that
one.
this is touching.
This is, yes, sir. Shark fin, so bronchospasm or tube.
Okay.
Yes,
yeah. So the ETC bronchospasm, ETCO2, and again your ventilator graphics also can be a part of in your exams. It can still come. Yeah. Okay. So this one.
This one is a esophageal.
Yes. Right.
Intubation.
Yeah.
Yes.
These two. The last one.
So this is hyperventilation.
CPR ROSD.
Yeah. It's CPR ROC because it's the same thing. I should have mentioned it. It's the same thing. So maybe here they're trying to be effective. They're trying to keep it more than 20, and here it just raises. Yeah. So it's ROC. Okay. Good, Dr. Manudeep. Yes. Yeah. So Hemant, Dr. Hemant, will you take this up?
Yes, sir.
Yeah. Yes.
Sir, it is a tracheostomy tube.
Okay. Right. So I think again the same, the cuff, the pilot band, the cannula, right? Okay. So when you do the tracheostomy, right, you do a percutaneous tracheostomy, right?
Yeah.
Yeah. So which technique do you use? The description. No, what is the name of the technique?
Sir, name I don't remember, sir.
Ciaglia, sir.
Yeah, modified Ciaglia, right? Exactly. Yeah. So when do you perform a tracheostomy? Yeah. How do you think the tracheostomy will help in weaning a patient? So what are the benefits of this tracheostomy in weaning? How does it help?
So it reduces the complications of ET tube. The patients are better, like oral care can be done better.
Okay.
Less incidence of VAP.
Okay. Then
so during weaning, actually we can deflate the cuff and ventilate.
No. That is tracheostomy wean. I'm just talking about somebody on a long-term ventilator. So you do a tracheostomy to facilitate weaning, right? Yeah. So better tolerated, less sedation, patient is awake. Then
early mobilization.
Early mobilization. Okay. Then
decreasing the ICU days.
Pulmonary toileting. Okay.
Better tracheal toileting.
Yes. Then
decrease dead space ventilation.
Yes, exactly. Decrease dead space and
Decrease resistance for ventilation.
Resistance, yes. So it will help in decreasing the work of breathing. All right. So I think, yeah, Sriram wanted to talk about this. So how do you perform a tracheostomy wean? So now the patient has got a tracheostomy, and now from tracheostomy, you have to decannulate.
Yes, sir. So we have to, yes, sir. First, we have to see whether the patient basal, whatever the basal thing, what is the reason?
So the reason for
intubation has to get resolved.
All right.
Has to get resolved, sir. And patient has to be clinically stable.
Clinically stable. Okay, good. Yeah.
Hemodynamically stable, clinically stable, conscious oriented.
Conscious, awake. Then
conscious, awake, and oriented, and he has to the hand grip has to be there, sir. Hand grip, and all the ventilator parameters has
he
to
should have a good cough reflex also, correct?
Good cough and reflex, sir. Yeah.
Okay.
So all the
prerequisite is fulfilled, right?
Yes, sir. Then we have to deflate the cuff, sir. And there should be minimal secretions. There shouldn't be any secretions, sir.
Okay, right.
And then we have to deflate the cuff for 24 hours, sir.
Okay.
And then allow the patient to breathe.
All right.
Then we have to measure we have to see the ABG, sir.
Okay. So
ABGs, right. And we have to measure the mean expiratory pressure also, sir. It should be more than 40.
Okay. So, okay. I mean, anything else you would like to tell?
Cough reflex has to be adequate, sir.
Okay. So before, I mean, once you deflate, something else also you simultaneously keep doing.
You have to check the airway obstructions or any airway.
Yeah. So how do you do that? How do you do that?
We can do bronch, sir.
Bronch? No. Okay. I mean, can be.
Cuff leak.
During tracheostomy wean. So have you heard something like gloved finger occlusion test and all?
Yeah, sir, but I don't know.
Have you heard about Sriram, yes.
Sir, I heard of it, sir, but I don't know.
We usually don't do it, definitely, yes. But other things we can still do. We consider, we deflate the cuff, we allow them to breathe. Then we can introduce a speaking valve and we can see how they are tolerating that, right?
Yes, yes, sir.
Yeah. So after, with all this, if they are doing okay, then maybe I think, then you can, put some cogs, occlude it, see how they are doing it. How that for 24 hours, and then maybe finally get ready to decannulate, right?
Yes, sir.
Yeah, right. Very good, Sriram. Yes. So something about TrackMan trial?
Yes, sir. There is they have compared the early tracheostomy and the late tracheostomy.
Okay, early is how early?
Early is less than 4 days, sir.
Yes, exactly. Yeah. And late was?
Late is more than 10 days.
Okay. So there was no mortality benefit that we all know. Yeah. So what did they find out, but what is the drawback of this?
The complication related to the tracheostomy is high, sir.
Yeah, I mean, both, yes, that was there. But apart from that, the early group had something, yeah.
The early group had more number of patients getting enrolled into the
Yes, exactly. Yeah. So you can still wait till 10 days and get a tracheostomy done. Okay. So you guys need to know about something called set point 2 trial also, that is specifically for severe stroke. Even that didn't have any functional recovery in stroke patients, right?
Yes, sir.
Okay.
So
okay.
there is one doubt in this, sir. Like they said, like even the patient is having the low GCS also, we can decannulate the patient so that the number of ventilated has come down. Is it reliable? Like there are some studies they said.
No, definitely. But the thing is, at the end of the day, the clinical, low GCS is able to cough, is able to clear out the secretions. So if he's not doing that, if the patient is not doing that, then the whole purpose of doing a tracheostomy is in vain, right?
Yes.
Okay. Yeah. Okay, Sriram. Good. Yeah.
So which trial did you mention? The stroke patient.
Set point 2.
Can you spell, please?
SET point.
Thank you, sir.
Yeah. Okay. So who's going to take this? Nithilan Bharati. Dr. Nithilan?
Yes, sir.
Yeah.
It's a heat moisture exchanger.
All right.
HME filter.
Okay. So there are two types of humidification, as you know, active and passive. So which one does this come into?
It's a passive way of humidification.
Okay. Right.
It's
right.
basically the used in an endotracheal tube or a tracheostomy tube.
Yep. Yeah.
It uses the patient's own temperature, the heat from the patient's own expired air, and it humidifies the air.
Yes, exactly. So the patient expired gas just comes here. There is a hygroscopic salt which has some reaction, and with the next inspiration, that will release the water vapor, right?
Yes.
Yes. So even this will have a filter too. So it's the bacterial and a viral filter. Okay, right.
Yes.
So briefly about this absolute humidity and relative humidity, can you just enlighten us?
Absolute humidity is how much humidity the gas, whatever the patient is inspiring, is having, is what the absolute humidity is. Relative humidity will be in relation to if the temperature is very low, then the capacity of the
is not there. Yeah. So the definition you can say is the same amount of water vapor for a given amount of gas required to saturate at 37 degrees, right? Yeah. So I think the mechanism you already explained to us, right? So advantages.
Advantages, it helps in preventing drying of
secretions. Very good. Yes. And purification will again, the ciliary function is maintained.
Ciliary function improvement.
Yes. There is some evidence towards prevention of VAP as well.
Better than heated humidifier.
Better not, but similar. That's what. Yeah. All right. Okay. Good, Dr. Nithilan. Good. So who will take this up?
So I will take, sir.
Okay. Yeah, Sriram. Yes.
Sir, this is a oropharyngeal, mask, sir. Oropharyngeal mask.
No.
NIV, sir, non-invasive ventilator.
Yeah. Okay. No, I thought. All right. Fine. Yeah. So different types of interfaces.
Nasal, sir.
Correct?
Nasal,
oronasal,
oronasal, and
full face,
face, sir. Full face,
and
sir.
helmet.
Yes.
Right? Okay, fine. So now if there is a patient you want to initiate on NIV, right?
Yes, sir.
So there are a few prerequisites which is all there, the indications which will discuss next. So now we have to start NIV to a patient. So how do you start? How do you
So depends upon the respiratory rate of the patient, sir. If the patient is tachypneic, and depends upon the indication, what the indication why we are putting.
So that indications will go next. So now we have decided to initiate NIV. So
so we have two things, sir. That is inspiratory IPAP and EPAP, sir.
All right.
So IPAP, we have to start with 10 centimeters of water. And
before that, first we'll tell the patient, find the harness, just keep the mask on the face. So all this, the bedside things you can still tell here. Yeah.
Yes, sir. So we have to counsel the patient.
Yes,
first.
Exactly.
And what he is supposed to do whenever the air comes, he has to take it.
Yes.
And coming to the ventilator settings, sir, we have IPAP, EPAP, and that is PEEP in the
ventilator. Yes, exactly.
And FiO2 and pressure support.
Yes, brilliant. Okay. Yes. Yeah.
So initially we start with 10 centimeters of water, sir.
Low. You start with low and then go.
Then we'll slowly increase, depends upon the tidal volume measurement.
Yes, exactly. So IPAP is done. Okay. FiO2.
FiO2 we titrate to the oxygen saturation more than 90, sir.
Yeah, depending on the need of the patient. Okay. Then EPAP.
Then EPAP depends upon the oxygenation, sir. Like we maintain the pressure difference between pressure support difference at least 4, sir.
Yes, at least 4 has to be there. Okay, right.
So that acts as a pressure support.
All right, fine. So now you've done all this, okay, and you have ruled out a leak. Okay, there is no leak. Okay, so there is a COPD patient. So you have done all this, but the ventilator there is no leak.
Sir.
The ventilator is not sensing, it's not triggering. The patient is not able to breathe.
Sir.
No trigger. So what do you suspect now?
There is an auto peep, sir.
Yes, very good, very good, very good. Right. Yeah. So now, what are the grade 1 recommendations of NIV?
So there are two, sir. Two things.
Okay.
One is cardiogenic pulmonary edema and type 2 respiratory failure in COPD patients.
Okay. So can you elaborate a bit about this type 2 respiratory failure in COPD patients according to the ERS, what all you have mentioned?
Sir, type 2 respiratory failure includes both hypoxia and hypercapnia, sir.
Okay. Yeah, that is there. No, the ERS recommendation for COPD.
Sir, I'm not sure.
Okay, so they recommend this for hypercapnic COPD patients, respiratory failure patients. That is number one. And what are the target? I mean, what are they seeing when before recommending? When do you put patients on NIV rather? So
when the work of breathing is too high, sir.
No, in COPD, work of breathing, yeah. So will you look into the pH or will you look into the CO2?
Sir, we look into the pH, sir.
pH, yes, exactly. So with the pH of 7.25 to 7.35, this is exactly what the ERS is saying, right? Hypercapnic COPD patients, respiratory failure patients, acute on chronic respiratory acidosis is also mentioned. So when the pH is less than 7.35, you initiate NIV, okay? And the chance of NIV failure is higher if the pH is less than 7.1. But nonetheless, try for all COPDs. Okay. So these two are grade 1s. So any other indications you can think about for NIV?
Sir, cardiogenic pulmonary edema.
Yeah, those two are grade 1s is done. Yeah, grade 1 is done. Yeah. Anything else?
From weaning, sir, in a prolonged weaning.
Prolonged weaning with, the guidelines say that with risk factors of COPD and cardiac patients. Okay. Yeah. Then you can use it in immunocompromised patients.
Yes,
right? And
you can
use this.
Sir, in ARDS also it can be recommended, sir.
We'll come to that.
Neuromuscular disorder.
Neuromuscular. Okay. ARDS will come to that is in the next one. Yeah. So okay. And post-operative respiratory failure. Okay. Right. So Sriram, you were saying something about ARDS and NIV.
Yeah, sir.
What did lung safe study tell us about this?
Sir, I'm not sure about the lung safe.
Okay. So basically, if there is ARDS, right? And with the moderate and severe ARDS, the chances of NIV failure is high and it increases the mortality. So for NIV, I mean, I know with all this COVID, we used to do all HFNC, NIVs and all. Yeah, definitely it's there. But it's not a good indication for NIV, especially if it is moderate or severe. Maybe you can use it like, to bridge before intubation or something like that. Yeah.
Yes, sir.
For ARDS, it's not that good thing. And even the ERS recommendations say they recommend again. So they don't give any recommendation at all for ARDS, de novo ARDS. Okay.
Yes, sir.
Right. Yeah. So about this HECOR score?
Yes, sir. HECOR score depends upon this score. We can predict the failure of the NIV, sir.
Okay. So, I mean, just briefly, the components. I don't want the score, numbers and all. What is H?
H is for hypoxia, sir. Heart rate.
Heart rate.
Yeah. A for acidosis, sir.
Yes.
C for confusion.
Yeah, GCS, very good.
O for oxygenation. R for respiratory rate.
Yeah. So if you calculate a HECOR score after 1 hour of initiation of NIV, and if the HECOR score is more than 5, yeah, there are parameters, if it is more than 5, it indicates that the patient can fail NIV. Okay?
Yes, sir.
Right. Very good, Sriram. Good. Yes. Yeah. So the last one. Dr. Deekshita Rajesh, can you talk about this?
Yeah, sir. It is a HFNC.
All right. So how does this help in respiratory failure?
It mainly helps in hypoxic respiratory failure. That's type 1 respiratory failure.
Yes. Yeah.
And as there is an increased flow rate, there will be high flow or oxygen supply over, and that helps in oxygenating the patient.
Yeah. So
FiO2.
so it reduces one is it provides humidification, right? Yeah. The second thing is washout of the upper airway, the nasal airways, right? And it reduces the dead space. It gives some sort of PEEP, okay? Yeah. And it does not allow for entrainment of ambient air. So you can titrate the FiO2, which is getting delivered to the patient. So ultimately, all these 5 things put together reduces the work of breathing, reduces the chances of villi, and it improves the ciliary function. Okay, fine. Yeah. So anything about Florali trial?
Florali trial. It helped in oxygenation, means the oxygenation improvement was there between the groups, but there's no mortality benefit as if I know. I'm not sure about it.
Okay, no, yeah. So Florali, they again, they looked into the benefits, mortality benefits, yeah, exactly. So they compared HFNC with NIV and standard oxygenation, okay, standard oxygen through a face mask, yeah. So in moderate ARDS, so when there's a post hoc analysis that if the PF ratios when it is less than 200, yeah, Florali improved. It improves the survival of the patient, right, compared to the standard oxygen and the NIV. So when when the ARDS, when you're talking about what sort of oxygenation you can, how to oxygenate the patient, HFNC stands better because the post hoc showed the mortality benefit also. And the primary analysis of Florali, they looked into the intubation rate at 28 days. So again, the patients on the HFNC group didn't require mechanical ventilation. Okay. Right. Yeah. So any scores, to predict failure on HFNC?
A ROX score.
ROX index, yes, ROX index. And at the end of 2 hours, if it is less than 3.8 or something, 3.8, it has a failure. All right. There is one more ROX HR also, that also you can look into. Okay. Right. So all the best, guys. So the next session will be on drugs. All the very best for your exams.
Thank you, sir.
Okay.
Thank you, sir.
Thank you. Thank you.
Thank you, Ganesh. I'm sorry I couldn't log in at the beginning of the talk. Much appreciate your help. And it's been a very interactive session. As you're just seeing, I just got out. I'm sorry. I got held up. I probably invite Dr. Pooja, again from Fortis Hospital, Bannerghatta, to do the drugs towards the exam session. And I welcome Dr. Pooja, please, to log in.
Okay, sir. Thank you, sir.
Okay, am I audible to everyone?
Yes. Yes, ma'am.
Yes,
yeah, and my slides are visible?
Yes.
Yes.
Yeah. So, okay. So this second half of the session, we are going to deal with medications basically. So when a drug is handed over to you in your exams, if you approach it in a systematic manner, then you will have quite a bit to say about the drug and you will not miss out on the important points. So I have made this pattern in which when a drug is given to you, you first tell what that drug is. It is available in which form it is being given to you. Is it an injection? Is it a tablet or a capsule? What is the strength? That is it 50 milligram per ml or what is the strength of the tablet? What group of drug it belongs to? What is the mechanism of action? What are its uses? A little bit about pharmacokinetics and pharmacodynamics, because in certain medications, it is important, the bioavailability, T-half, how it is eliminated, the dosage, the important side effects, and a little bit about evidence also. So if you go this way in a systematic way, you won't miss out on the important things. So I have incorporated few important drugs from each category. I will present the first drug myself, and following this, I would like to have a very good interactive session over here. So I'll hand over the rest of the drugs to you. So this is injection amiodarone, which is 150 milligram in 3 ml ampoule. It belongs to the class 3 antiarrhythmics. Its action is blocking the potassium channels. It also blocks beta-1 calcium and sodium channels. It has a half-life of several weeks. It can be given IV and peroral both. It has a good oral bioavailability. It is metabolized in the liver. It is used in most of the arrhythmias, like supraventricular arrhythmias, atrial fibrillation, VTVF, and it's also part of our ACLS protocol. We come to the side effects. It can cause prolonged QTC and bradycardia, AV blocks. Along with that, pulmonary toxicity, corneal deposits, hypothyroidism, liver toxicity, and neurotoxicity. So in short, this drug, if you mention it in this way, cover the most of the things about the drug will be covered. So we will go to the first drug. I would, anyone interested in taking up this drug?
Yes, ma'am, I'll take this.
Yeah, who is speaking?
Dr. Sriram.
Dr. Sriram. Okay, Dr. Sriram.
So this
tell me about this.
Yeah, polymyxin B, ma'am. This is a IV formulation. It belongs to polymyxin group of antibiotic. Other polymyxins are polymyxin E, that is also called as colistin.
Yeah.
The mechanism of action is it causes cell membrane leakage and causing a cell death. It's a
it acts on the lipopolysaccharide
on the
cell
cell membrane
and create
the effects. Spectrum of activity is gram-negative, ma'am, mostly.
Exactly, and it also in high doses it can have antitoxin effect.
It's a concentration dependent drug.
Exactly. So can you compare polymyxin B and colistin over here?
Yeah, polymyxin B, there's relatively, when compared to the colistin, it has a less nephrotoxicity.
Okay.
Dosage, coming to the dosage, the polymyxin B.
Dosage will be different for both the drugs. Dosage will be different.
Yes,
anything else? Polymyxin B and colistin. So which has more urinary concentration and which has more systemic concentration?
Colistin has more urinary concentration.
No, exactly. Colistin. Yeah, colistin, and which one is the colistin? Yeah. And which one is the prodrug?
Prodrug is colistin is prodrug.
Yeah. So colistin is the prodrug, and colistin achieves almost 65% urinary concentration, but polymyxin only 1% of the concentration is achieved in the urine. So it is good for systemic infection, while for colistin is very good for urinary tract infection. Okay. We don't have much PKPD details about polymyxin. We have lots and lots of studies regarding colistin. And colistin, the only form IV is available, but colistin, you know that it can be given by nebulization and
the nebulization
also.
Yes.
Yeah, exactly. So what is colistin intrinsically resistant to? Polymyxin is intrinsically resistant to?
Anaerobics, ma'am. Anaerobics
okay,
and
anaerobes, then?
Gram positive.
Gram positive, then?
And Burkholderia and Brucella. Burkholderia also it's intrinsically resistant.
Yeah, so and other than the GPC anaerobes, this group of organisms, Proteus, Morganella, Serratia, Providentia, Burkholderia, polymyxin does not act.
Yes.
Okay. And side effects?
Nephrotoxicity, ma'am. It can cause nephrotoxicity.
Yeah. Anything else?
Thrombocytopenia.
Not really. Something which is very common with polymyxin. Any other systemic effect? Any other systemic effect?
Neurotoxicity.
Exactly.
Neurotoxicity, ma'am.
Okay.
Neurotoxicity.
Yeah. So dizziness, loss of consciousness, seizures, myopathy, all those things are seen with polymyxin. Okay.
Yes.
Yeah. So who wants to take this? In case you are not able to read this, this is 3% saline. Who wants to take this?
I'm sorry, ma'am. Can you please show the first slide of polymyxin once, please? Thank you, ma'am.
Yeah. So who wants to take up this? This is 3% saline. Anyone? Somebody please pick this drug up.
Ma'am, I'm taking this. This is 3% saline, and it's containing 513 sodium and 513 of milliequivalents of chloride.
Yeah, always use the unit.
Okay, milliosmol of 500 130 milliosmol.
Yeah.
And the osmolality around 1050, I think, 1026.
Okay, how do you administer this? Do you use 3%?
What, ma'am?
Do you use 3%?
Usually we'll use in neuro cases like where there's any traumatic brain injuries or any increased ICP, such cases.
So how do you administer this drug?
Initially, we can start with around 150 to 250 bolus we can give. Follow that we can around 100 or 150 ml per hour we can.
So following that bolus, how do you give?
According to, we'll keep a target of sodium around 140 to 150 target, then we can administer.
So after a bolus, you continue it as an infusion?
Yes, ma'am.
Okay. So what is the evidence for 3% compared to mannitol when it comes to raised ICP? Which one is better?
3% is better, ma'am.
Both are equivalent. Both are equal.
No evidence to prove that one is better than the other. But studies say that mannitol, when it's given as boluses, it can be used in boluses and acute rise in ICP. But 3% saline, as it's given as infusion, there will be a continuous control of ICP. But
yeah, so there is no clinical evidence to of superiority of 3% over mannitol. But in some TBI cases, that is traumatic brain injury and ICH, mannitol was found to increase the size of the hematoma as such. Okay, and
there is a recent trial. There is a recent trial, ma'am, on 3% and mannitol. This shows like there is no evidence which is superior, but they say 3% is having a more cerebral perfusion, and it's a prolonged action when compared to mannitol.
Yeah, it has got a prolonged action. And other thing is we use here 3%, but there's 21% also available, which we give generally as it comes in a vial. It's given as a bolus, and that is not done as an infusion. So whenever there is a raise in ICP, it is given as a bolus as such. Okay. So how do you compare it with mannitol with regards to duration of action, onset of effect?
Mannitol, I think it will take 15-20 minutes to act. NS, it's an immediate action will be there.
Okay, which acts longer?
Mannitol acts longer.
Mannitol acts longer. And what is your target with mannitol when it comes to raised ICP?
Serum osmolarity. Osmolar gap we have to keep in mannitol.
How much you want to keep? Yeah. So hypotonic saline acts faster than mannitol, and that has a longer duration of action. So he just mentioned it sometime now that it acts for a longer duration. When you're giving 3% sodium, you maintain a sodium level of 145 to 155. But when you're giving mannitol, you have to keep your osmolar gas less than 20. That's how you monitor mannitol. So the next drug, who would like to take this? Anyone? Quickly, we have only half an hour left. Anyone? Otherwise, I'll have to pick up.
Okay, I'll take it, ma'am.
Yeah.
It's a cardiac glycosid group, ma'am.
Okay, mechanism of action?
So sodium potassium ATPase inhibitor, ma'am.
Okay.
It comes in a so it causes an increase in the cardiac contractility.
it increases the intracellular sodium and calcium. So that way inotropy increases, and by the vagomimetic effect, it decreases. It has a negative chronotropy.
Yes.
So bioavailability.
I'm not sure, ma'am.
Yeah, it has 70% oral bioavailability. Is it dialyzable?
Yes, ma'am, it's dialyzable.
No.
No, it's
digoxin is not dialyzable. What is its half-life? It's very important, especially when it comes to patient who come with acute kidney injury and the patient is on digoxin.
Yes, ma'am.
So normally it's 2 days, but in patients who are anuric, it can go up to 5 to 6 days also. Okay.
Yes.
So not to mention that route of elimination, definitely it has to be renal only.
Yes.
Yeah. So how does the toxicity present with?
It can present with any kind of arrhythmia, ma'am.
Exactly. Yeah. What else?
It can cause hyperkalemia.
No, it doesn't cause hyperkalemia. Hypo or hyperkalemia can precipitate the toxicity of digoxin.
Yes.
So anything else in ECG?
ECG, it can cause.
Others can also contribute. Have you heard about the reverse tick sign?
Yeah, yes.
The Salvador Dali's.
Yeah. And color disturbances are also very common. So how do you manage toxicity?
FAB, we have to give them.
Yeah. So this one FAB, and you need to correct hypokalemia and hyperkalemia. Okay.
Yes.
So who wants to take this? Hemant? If nobody is volunteering, then I'll have to pick up the names myself. Hemant? Anybody wants to volunteer? Ambika?
Hello?
Yeah, tell me.
Hello?
Yeah, tell me. So what is this drug?
Yes, ma'am. This is meropenem. It's an antibiotic. Mechanism of action is it binds to protein, binds to penicillin binding protein and inhibits transpeptidase. It has bactericidal activity. It causes disruption of the cell wall synthesis.
Okay. What are the other drugs in this group?
Ertapenem, imipenem, and doripenem.
Okay. And what is this microbiological spectrum?
It covers gram positive and gram negative also. In gram positive only MSSA, Streptococcus pyogenes and agalactate, and gram negative it covers E. coli, H. influenza, then Klebsiella pneumoniae, Pseudomonas. Then it also covers anaerobic microorganisms like bacteroides, and then Pectostreptococcus species also.
Yeah. So is it concentration dependent or time dependent? How do you give this meropenem?
It's a time dependent. It's infused over 1 to 3 hours.
Yeah. And what are the side effects that you see? Forget
Side
about nausea,
effects?
vomiting, and all those things. Yeah.
Yes, ma'am.
Seizure, ma'am.
Yeah. Seizures?
It is a nephrotoxic also.
Renal toxicity.
Renal toxicity.
It doesn't cause renal toxicity. You just have to modify the dose when there is injury or a quantity.
Based on the creatine clearance, we have to modify the dose, ma'am.
Yeah, you just have to modify the dose. Thrombocytopenia, okay?
Seizure and thrombocytopenia.
Yeah. So in imipenem, what is the role of the celastin? You know, imipenem comes with celastin, right?
Yes, ma'am. Celastin, yes.
Yeah. So what is the role of the celastin in imipenem?
Celastin inhibits the dehydropeptidase enzyme in the renal tubule, ma'am. So it prevents the degradation of imipenem.
Exactly. And what is the choice of carbapenem in pancreatitis?
Ertapenem. Imipenem.
Yeah. And ertapenem is intrinsically resistant to?
Pseudomonas, ma'am.
And you know any oral carbapenem that is available?
Ferropenem. Ferropenem.
Yeah, and this carbapenem group is intrinsically resistant to which bacteria? Gram negative? Chinotrophomonas. Yeah. So who wants to take this? This is 0.9% normal saline. Who wants to take this quickly? Please volunteer.
I'll take, ma'am.
Yeah.
So it's a normal saline, 0.9% normal saline. Osmolality is 308, ma'am. 308.
So how much is the sodium and chloride in that?
Sodium is 154 and chloride is 154.
So what is the problem that you have with large volume normal saline infusion?
Hyperchloremic acidosis.
How does this acidosis
causes vascular renal artery vasoconstriction? So that causes the renal.
Not renal artery, it causes afferent glomerular vasoconstriction.
Afferent glomerular.
Okay. Yeah, that way the glomerular filtration comes down. This hyperchloremia is sensed by the macula densa, and the afferent arterioles are very close to it, and that's how it causes the afferent glomerular vasoconstriction, and hence the decrease in glomerular filtration. So why do you see hyperchloremia more than hypernatremia when you give large volume saline infusion?
Strong iron difference in.
Not that. Just that the chloride level in normal saline is almost 50% higher than what is there in the serum compared to the minimal difference in sodium levels in the serum. Okay, so that's why the hyperchloremia is what you see more. Okay. So a little bit on the evidence when you compare normal saline and
there are plus study was there, ma'am. Recently, that is 2020. That shows there is no difference between the normal saline and the balanced salt solutions. And other studies are like basic study, salt ED study, and the 6S trial.
So yeah, so the last one was the plus study that did not show any difference. Basic also did not show any difference. Okay. So you should be aware of at least the names of and what the last study showed. Should be aware of that at least.
Yes, ma'am.
Yeah. So who wants to take this? Anyone?
I'll take.
Yeah, please tell me. What was that?
It was hydrocortisone. It belongs to the class corticosteroids.
Okay.
So
what does it have? Action?
It has meaning hydrocortisone has mostly glucocorticoid actions, ma'am. Anti-inflammatory and then immunosuppressant
but it,
with some
amount of mineralocorticoid activity also. So what is the duration of action and how do you give hydrocortisone?
Hydrocortisone.
Yeah.
It's usually given as IV route, and duration of action is around 10 hours.
Yeah.
And indications in ICU, it can be given as in shock. We can use in septic shock mainly. When there is adrenal insufficiency, we can use it. And we can also use it in, it can be used as a immunomodulatory drug.
In fact, the accountant wo lady jo rehti thi, she also agreed that.
And other effect of steroid is it can be used in meningitis, mainly streptococcal meningitis and tubercular meningitis. And we can also use it in certain neuromus like GB syndrome.
Yeah, autoimmune emergencies, vasculitis.
Yeah.
So in addition to whatever you said, and also acute exacerbation of reactive airway disease.
Yes, ma'am.
Yeah. So these are the 5 indications. There are more indications, but there are 5 indications if you ask. This is good news. Okay. So what are the prolonged problems with prolonged usage?
Prolonged, they are prone to infections, and then urea can go up, and then
adrenal suppression. Adrenal suppression.
Yeah, adrenal suppression can.
Yeah.
HPA access.
Yeah, HPA access suppression.
Hyperglycemia, ma'am.
Hyperglycemia, very good.
And critical illness, polymyopathy.
Myopathy, yes. Okay. So what is the next one? Have you heard about this?
It is critical illness related corticosteroid insufficiency.
Yeah. So what are the features of it? How do you identify this? Clinically?
Mainly myopathy.
Clinically and lab-wise.
Patient
so
won't
it's a
come
sign
out
of
of the
insufficiency. It's not a side effect. I'm not asking about a side effect of steroids.
patient won't come up the shock. You can't wean off the vasopressor supports. So minimal vasopressor going on.
Okay, hypotension is one thing. Other
Refractory hypoglycemia.
Hypoglycemia. Then anything to the electrolytes? The usual electrolytes. What happens? Sodium and potassium. What happens?
Hyponatremia can be a possibility.
Hyponatremia,
hyponatremia and hyperkalemia.
Yeah. Any other clinical features? So persistent fever, confusion, those can also be features of critical illness related corticosteroid insufficiency. So when somebody is on steroid, how do you stop the steroid? Do you need to wean the steroids or do you need to abruptly stop it? So how do you decide what to do?
It depends on the duration on which the patient is steroid for.
Okay. So when do you stop it abruptly?
If it's less than 2 weeks, then we can stop it abruptly.
Yeah, they say up to 3 weeks, you can stop it abruptly. So what is the role of steroid in septic shock?
There is a relative adrenaline insufficiency in septic shock. So giving steroids will help.
So what was the last, you know any studies regarding the steroids in septic shock?
Adrenal and approaches trial, ma'am.
Yeah, so what did the adrenal study say?
Adrenal trial is a negative trial. It doesn't show any mortality benefit, but approaches shows that when hydrocortisone is supplemented with fludrocortisone, so there is a improvement.
Yeah, so approaches had fludrocortisone added, but adrenal there was this subgroup also that showed that there was a faster recovery of shock, less ICU duration, less mechanical ventilation, less blood transfusion, just that there was no 90-day mortality benefit. Okay.
Yes.
Yeah. So who wants to take this? Anybody? Anyone? Quickly. Umesh?
Yes, ma'am.
Yeah, you want to take this drug?
Yes, ma'am.
Yeah.
It is a heparin anticoagulant, madam. It is available
What
in
type of heparin is this? What type of heparin is this? This one which I have put you over here.
Unfractionated.
Unfractionated heparin.
Yeah, this is unfractionated heparin. So how does it act?
Antitania.
Anybody else? Anyone wants to contribute?
Antitania.
Indirect thrombin inhibitor.
An antithrombin.
Antithrombin 3 inhibitor.
Yeah, and what does that happen? What does that do? It binds to antithrombin and further?
That usually will inhibit the thrombin. This will prevent it
thrombin
from action.
Thrombin and one more factor?
10A factor.
Factor 5.
10A factor.
10A. Yeah, 10A factor. So how do you monitor the therapeutic effect of unfractionated heparin?
APTT monitoring.
ACT or APTT, ma'am. Either of the two things.
Yeah, anything else?
Factor 10 also.
Yeah. So what routes can you give this heparin?
IV and subcutaneous.
And half-life of heparin?
3 hours.
4 hours.
6 hours.
12 hours.
Just up to 2 hours only. 12 hours. To maintain therapeutic effect, you have to run heparin infusion only, right?
Yeah.
So what is this?
Heparin-induced thrombocytopenia.
Thrombocytopenia with thrombosis.
Yeah. So what exactly is it?
It is an immunological response to heparin because of the platelet factor 4 inhibition, which results in thrombocytopenia as well as formation of thrombus.
Yeah. So that you are typically telling about the type 2 one. Okay.
2-1.
There is yeah. The immune mediated one is a type 2 one. So basically it is a prothrombotic complication associated with thrombocytopenia when in case of heparin. And what is the type 1?
Type 1 has only thrombocytopenia without thrombosis. And the platelet
Yeah, so
natriuretic.
which one is immunological and which is non-immunological?
Type 2 is
Type 2 is
immunological.
immunological, type 1 is non-immunological.
Yeah. So how do you diagnose this HITT?
We can calculate the 40 score.
Yeah, so that's the pre-test probability is there, 40 score. Then
platelet
other than that?
Or antibodies we can test.
Which antibody?
Hit antibody.
No, what is antibody? What are you trying to test?
Platelet
what are you trying to detect?
Platelet antibody.
So, and another assay? Anything else? The serotonin release assay for the functional assay. So, what is the reversal agent?
Protamine.
Protamine sulfate.
Yeah. So, who wants to take this?
Ma'am, this is human albumin, ma'am.
Yeah.
It's available.
So, what concentration is this? Can you see it?
It's 20%.
Yeah. So, what other concentrations are available?
25% is available, ma'am. 5%.
10%.
10%.
5%.
5% and 25%.
So, what is the half-life of albumin in the body?
Not sure.
12.
Okay, so it says for 19 days, the half-life is 19 days. So you give me some indications of usage of albumin in ICU, which has proven to have mortality benefit. Not any off-label use. Yes, tell me.
Ma'am, in ARDS patients,
ARDS patients?
I mean, sepsis patients. Sepsis patients.
Sepsis, what is the role of albumin?
Ma'am, if there's a fluid resuscitation is too much, then we can give albumin as a resuscitation.
That is not shown to have any mortality benefit or anything.
Not mortal. Ma'am, ovarian hyperstimulation syndrome.
Hepatorenal syndrome.
Hepatorenal syndrome.
We use it for hepatorenal syndrome
and SBP.
SBP.
Suspecting SBP.
SBP.
With renal failure.
And high volume paracentesis. Okay. So other off-label users, now you can tell me what all you wanted to tell.
I mean, plasmapheresis.
Somebody was telling ovarian hyperstimulation syndrome.
In plasmapheresis also you can give.
Yes, plasmapheresis. Yes. Yeah.
To restrict the volume of infusion in case of volume resuscitation in case of burns.
Okay, and septic shock where high volume resuscitation is required. Then there is something called albumin and furosemide also is being tried. That is where you find a furosemide resistance. Then in HIPEC surgeries post-operatively, when there is a lot of output from the abdominal cavity, so in such patients also albumin has been used off-label. Contraindications?
Traumatic brain injury.
Okay.
And any allergic reactions, ma'am, to albumin?
Allergic reactions, good. Also, the group of Jehovah's Witness, they don't take albumin. So, who will give me the evidence for volume resuscitation with albumin?
Albios trial, ma'am, and SAFE trial.
Yeah. So, what did they say?
Yeah. SAFE trial, we can use it, like they compared between the saline and the 4% and NS does, but there is no much mortality benefit, ma'am, in SAFE study.
Yeah. In fact, SAFE subgroup showed that in TBI, there was increased mortality when albumin was used. Yeah. And the Albio study, it just showed that it improved the hemodynamics earlier when 20% albumin was used, but there was no mortality benefit in severe sepsis. Okay?
Yes.
Yeah. So coming to this drug, who wants to take? Anyone? Come on, easy drug.
It's a loop diuretic.
Yeah.
Mechanism of action.
Tell the name of the drug.
Furosemide, which is a loop diuretic.
Yeah. Okay.
Mechanism of action is through sodium chloride transport channels.
Exactly.
Side effects are hypokalemia, hyponatremia, and other electrolyte disturbances, hypotension, renal injuries.
Okay. So what is furosemide challenge test? Autotoxicity. Yeah. What is furosemide challenge test?
Furosemide challenge test is given at the dose of 2 milligram per kg, and at the end of 2 hours there should be a production.
Why do you do it? Why do you do it?
It is done mainly to see the functioning. I mean, if the kidneys are functioning or not.
Not kidneys are functioning. It's not
whether
that.
the functional glomeruli are present or not.
The integrity of all the glomeruli.
Yeah, the tubular integrity is present or not, and it will help you to what?
To differentiate pre-renal or renal involvement.
Non-oliguric
AKI.
No.
AKI.
So it just
Whether there is any
people.
functional glomeruli present or not.
Yeah, so if some functional glomeruli is present, that means the chances of that patient going in for an RRT, the chances are less, right? So it just helps you to identify such group of patients in whom the tubular integrity is still maintained. So how do you do this furosemide challenge test?
It is given at the dose of 2 milligram per kg, and patient is assessed for 2 hours, and at the end of 2 hours, it is expected that around 200 ml of urine should be produced.
Yeah. So the dose varies. So somebody who is naive to furosemide, the dose is 1 milligram per kg, and somebody who's been on high dose of furosemide already, then you end up giving 1.5 to 2 milligram per kg of furosemide. Okay. So what are the routes of administration?
IV administration and oral administration.
And what is the difference between IV and oral? Which acts faster?
Intravenous acts faster.
And what is the efficacy between the difference in efficacy? Which is more efficacious? So the oral only has 50% bioavailability. So that's why when you're putting somebody on oral, you usually put up a higher dose of oral furosemide compared to what he was receiving in the IV form. Okay. Yeah. So who wants to take this?
So we'll do that as a last one, Dr. Pooja. I think they have a session at 7, and we'll have a minute or two to just wrap
5 minutes
it
are
up.
there, right? Yeah. I'll go for this. Can one of you take this?
I'll take it, ma'am.
Yeah. So what is this? Which group of drug is it?
This is a neprilysin inhibitor, angiotensin neprilysin inhibitor, ARNI.
Oh, yeah. So what is this combination? Why this combination?
This one, the neprilysin inhibitor, mainly that acts by preventing the breakdown of the natriuretic peptides. So this is combined with the angiotensin mainly to counteract the effect of the neprilysin. It also activates the angiotensin too. So ARB is also used with it.
Yeah. So this is a combination of sacubitril and valsartan. Sacubitril is a neprilysin inhibitor in this. So it, along with that, when it inhibits the neprilysin, what happens is the angiotensin level or 2 levels also go up. So to inhibit that, this combination is given. So along with the ARB valsartan. Okay. So where is it used and what is the level of evidence?
It is mainly used in, it's a FDA approved drug for heart failure with low ejection fraction.
Yeah, with reduced ejection fraction. And what is the level of evidence? Class 1B evidence. Okay.
Okay.
So what are the advantages that this drug has?
Decreases the afterload.
So because of this neprilysin inhibition, there is a reduced dose of diuretics, remodeling, and still they want to have better glycemic control also with this drug. Okay, so this is how it acts by inhibiting this neprilysin. So this is what we need. We need this natriuretic peptide. Okay, which is the neprilysin usually breaks down this peptide. So we inhibit this neprilysin. But in the process, what happens is the angiotensin 2 levels also increase. So we need this to stop this man also from acting. That's the reason why valsartan is added. Okay. So last drug, who wants to take this? Divya?
I'll take this.
Okay, yeah, please.
So ceftazidime avibactam, ma'am, this belongs to third generation cephalosporin. Basically, it acts in ambulance classification. Is carbapenemase, beta-lactamase resistant, and we can use this ceftazidime avibactam in combination of aspirin.
So, which type of carbapenemase it is used in?
Ma'am, it can be used in class A, ambulance class A, class C, and class A, C and D, ma'am.
Yeah, A, C, and D. Okay. So for B, it is not effective, which produces the NDMs.
Yeah. Yes.
So what is the ratio of the combination?
2.5 is to 500, ma'am.
Yeah, the ratio is 4:1. That's how it is given. So what is the avibactam in this combination?
Avibactam is a beta-lactamase inhibitor, ma'am.
It's a non-beta-lactam actually inhibitor. Okay, it doesn't have the beta-lactam ring.
Okay.
All right. And suppose your variant is showing OXA48 plus NDM variant, then what do you do?
Then we have to combine with aspirin.
Exactly. So you will have to combine with aspirin. And what does it doesn't act? It doesn't act against which organism?
Tinotrophomonas.
So basically, one which has this NDM and also Acinetobacter. Okay.
Yeah. Thank you, ma'am.
Yeah. So I'm done with this. Other things like please go through vasopressors, inotropes, TPN. Difficult to cover everything in this one session. Antifungals, they're all very important. So please go through all of them. A little bit of evidence can come.
Share the slide of tranexamic acid.
Yeah, so tranexamic acid. How does it act? Basically binding to plasminogen and inhibits its interaction with plasmin, both IV and oral. It is eliminated through the renal route, and so it needs renal modification, renal dose modification, and evidence is basically CRASH 3 trial. CRASH 2 already within 8 hours of trauma in bleeding trauma patients, it reduced the risk of death. CRASH 3 showed mortality benefit when given within 3 hours of injury in mild to moderate traumatic brain injury.
Thank you.
Yeah. So all the best to everyone. Justin,
thank you, Dr. Pooja. Much appreciated. I think on behalf of the trainees in the IDCCM, I thank both Dr. Ganesh and Dr. Pooja, who's from Fortis Hospital, Bannerghatta, Bangalore, to have taken time and made a lot more interactive session this time. I could see that the Airway session and the drugs have been probably the most interactive. So hopefully it will come to some help in the training. So these sessions aren't designed to completely give you all the literature information at this time. These are a way to just prep you for the exam, just last minute crunch if there are any small things that are left. So that's the reason why. And also for those people who are not appearing this time, but probably next time, is a way to just prime themselves to see how to sort of approach exams when they come to it. So thank you, Dr. Pooja, again. And I thank Vinay from Hallmark, who's been coordinating the session through running the session. And I also thank seniors or others logged in today, Mahesha, Rajwardhan. So thank you, guys. And if there are any comments, please make it. But I would request all the trainees to log into the IDCCM exam session, which is Indian College of Critical Medicine is running an exam session for the exam going people. Please log into that. And tomorrow's session will also be at 5:30. Thank you all. Yeah, thank you.